Hello, everyone, and welcome to the PT on Ice Daily Show. Christina Prevett here. I am one of our division leads for our older adult division, and today I am bringing you a case study of a previous client of mine with moderate to severe COPD who did really well using a HIIT training paradigm. Now, I am going to call this man Bob. Bob came to me because I had been seeing his wife for a lower extremity osteoarthritis injury, and her husband was not wanting to acknowledge how severe his COPD was. So he had been struggling with COPD, previous smoker for quite some time, and he was kind of always on the edge of I should be using supplementary oxygen, but I am not. And so he was kind of living his life around 90, sometimes dipping to 89% O2. His doctors had recommended supplementary oxygen, but he was just not in this phase yet, maybe from an acceptance of his diagnosis, or he felt like having that O2 on him all the time projected an image that he did not want of his current status and capacity. And so he had been very reluctant and resistant to getting any type of supplementary oxygen. But as his disease progressed, the problem that he was getting into is that he would become very dyspneic very early. And so he was, wall walking or furniture walking. He was needing to take a lot of resting breaks when he was out in the community. He was kind of just really starting to struggle with ADLs, and yet still just wasn't in this place where he was ready to get any help or use that supplementary oxygen. And so he got referred to me, and his wife was like, "Is there anything that you can do?" And I said, maybe if we can increase his physical capacity, I can do a little bit more medical monitoring with his exercise. We may be able to build some resiliency, and I can probably talk to him about the pros and cons of, hey, it's not admitting defeat in your disease process to be using oxygen. So when he came in and we did his functional capacity, he was absolutely having low endurance. We did a 2-minute step test, and he was really struggling about 60 seconds in. And when we were looking at some of his functional strength or issues, he was having some problems, like more from he could get up out of a chair like without his hands, but he was getting really breathless if he was doing like a repeated chair stand or a 30-second sit to stand type of test. And so we decided to take a multi-pronged approach. He wasn't having any musculoskeletal pain, so this was very much in the cardiac rehab space where we were working on a multi-component program which encouraged functional strength training at moderate to heavy weights. And for him, doing higher load and lower repetition was actually better for his dyspnea, because when we had higher rep ranges, and if you've ever done a 10 to 12 repetition squat or deadlift, your heart rate really does come up and your oxygen need increases. And so we were doing lower repetition, higher load. And then we were finishing off our sessions with HIIT training on a rower. So when it comes to cardiac rehab, in Ontario, in Canada, where I am, we have seen some reduction in funding for cardiac rehab, which is really unfortunate. And I don't know if that's the case where you are, whoever is listening. And there is usually a big emphasis on cardiovascular events, and less individuals are coming in for pulmonary rehabilitation. But we have very strong evidence for the use of cardiac rehab for those with both cardiovascular and pulmonary conditions, of course. The leveraging of HIIT training in these pathologies has been growing in popularity over the last 5 to 8 years, where when we get into more subacute status or chronic, no big change in functional status, no acute hospitalization, leveraging a HIT training paradigm for those with COPD, emphysema, lung cancer, multimorbidity, subacute MI, or other heart surgeries all have evidence to back them up. And so his home exercise program was to be on a moderate intensity continuous training program, easier to handle. I do not worry about the supervision piece of it if he does end up desatting, and was something that was achievable for him at home. And then when he was in the clinic for me, we were leveraging HIIT training. Why I chose HIIT training was because his exercise tolerance was low. And you might be thinking, Christina, like, what do you mean that he's deconditioned? So you're leveraging a higher intensity protocol. When we were thinking about HIIT training, it's relative to the exercise tolerance status of the human that we are working with. And so, as I mentioned on his 2-minute step test, he really started to struggle about 60 seconds in. And so, for him, when we were doing HIIT training, that allowed me to figure out his work to rest ratios and allow him to alternate between higher intensity intervals and complete rest, which when you're on a rower, you can just stop pulling. And for his paradigm, what we did was we had him on continuous monitoring. I had him using a rating of perceived breathlessness or a dyspnea scale, where when he got to about 5 out of 10 of feeling breathless, we would stop and we would track what that interval was. And then I would look at his O2, and if he dropped below 90, that would stop our interval as well. So I kind of had a couple of checks and balances in place. And then what we would do is we would wait our rest interval, which was not set in stone, was when he was seeing this recovery to at least 92, 93, which was what he was walking in with, right? So we would kind of know that he was going to desat a little bit, would stop there, and then he would rebound. And the incredible thing that would happen with him, and this happened from time one, like session one that we did this with, was that he would walk in at a 92, 93. And by the time he was 4 or 5 intervals in, his O2 saturation would be sitting in the 95 to 97 range. And so when he was doing HIIT training, he was actually getting more efficient at drawing O2 out, and his blood oxygen levels were actually increasing. Now, this is a medically monitored game, right? Where for some individuals further along in the disease process, their dyspnea is too high. They're going to have a really hard time recovering, and you have to be very mindful about your work to rest ratios. But for him, it was a really powerful case for him, right? And he would be seeing this, right? So he would see that with exercise, he was actually getting better. His oxygen saturation was getting better, and he would walk out feeling a lot better than when he came in. The amount of intervals that you do is really going to depend on any rebound fatigue and any other more multimorbidity or comorbidities that are going on with the person that you are working with. But with him, he just became more efficient at drawing oxygen, and his O2 actually improved, which was incredible. This is one of those examples where I think we have such a powerful place, even as outpatient providers. So I was working in an outpatient setting at the time. When we think about our exercise traffic light, we an older adult that we live in the land of the yellow, where we have individuals who don't need us, right? They're in the green lights. They are doing all of the exercise that they want to be able to do. They're able to do all their ADLs and IDLs, and it's not a huge issue. When individuals present with pain, that is where they kind of move into the land of the yellow. But it's not just pain. Of course, pain is a very big driver for individuals to come into rehabilitation, of course. But there are so many other areas in outpatient where we can niche, right? And so, where this individual, what they were needing was not workarounds for pain, but an understanding of what was safe and understanding how they could push themselves when they're always kind of at a risk of feeling breathless or feeling like they can't catch their breath, which is such a terrible feeling to have. And so, how do you kind of move and wiggle within that? What feels safe? And him coming in knowing that one, I was monitoring him, two, that he could see the numbers himself, and three, he started to learn what that felt like we only had to do a couple of sessions before I could discharge him to do his own program at the YMCA that was close to his house. And so that is where kind of living in the land of the yellow for, kind of stable or maybe slower progressing chronic disease, like his case for COPD, preserved his function for a little bit longer. Eventually, he is going to need COPD or he is going to need supplementary oxygen. His COPD is progressing. But maintaining function and trying to maintain aerobic and resistance training fitness is going to help extend his functional capacity for as long as possible. All right. I hope that was helpful. When it comes to HIIT training, one of the things that we talk about in older adult level 1 is how one, our prescriptions don't have to be set in stone. That two, even though our data often is looking at a 1-to-1, 1 minute on, 1 minute off, or 4-to-4, 4 minutes on, 4 minutes off protocol, does not mean that that is the only protocol that is going to be effective. We know that we can be anywhere between 30 seconds and 5 minutes. We can have a 0.5 to 3 times multiplier on the rest. The rest can be complete rest or lower intensity movement. And all of that can be effective. When we have individuals like Bob that are more deconditioned, we are going to start with a smaller work interval and a longer rest interval. That rest interval is going to be complete rest. And as he improves or as he starts to get better tolerance to a HIIT training protocol, we can change those things up and know that what worked for him at round 1 may not be working at round 4 or 5. And it is absolutely okay to adjust to his current status. And that's where our skilled care comes in. If you all are interested in learning more about this type of prescription, our older adult level 1 course is getting started next week on the 20th. And so if you have not jumped into our online course, I highly recommend that you do this. Our spring cohort coming in just before the summertime, we're going to finish up. If you have any other questions about HIIT training in the background of cardiopulmonary compromise, please let me know. Otherwise, I will see you all next time, and I hope you all have a wonderful rest of your week.